Good afternoon. This is Dr. Marcelo Di Carli. I'm the director of the cardiovascular imaging program at the Brigham and Women's Hospital. And I'm going to continue on the series of non-invasive testing for the cardiology board review. My topic would be nuclear cardiology and PET imaging. The disclosures are listed here, none of which I think are going to be very relevant for the discussion of this presentation. So in thinking about nuclear cardiology and PET imaging, we need to start from the basics, and the basics will cover both radio tracers for imaging and imaging protocols. The three radio tracers listed on this slide, thallium, technetium sestamib, and technetium tetraphosphine, are the three clinically available tracers for SPECT imaging. As you can see, there are a number of differences between these tracers. The half-life is obviously different, longer for thallium, shorter for technetium. The photon energy is an important quality of these tracers, and you can see that both technetium sestamib and technetium tetraphosphine have better imaging properties for the type of gamma cameras that we use. And because the energy that we image is higher, there's much less scatter, photon scatter, and better image quality in general. The other important aspects of the characteristics are the measurement of hyperemic flow, or the peak flow, is good or excellent for thallium imaging, is adequate, moderate for sestamib and tetraphosphine, and the image quality of the gated images, because of the higher energy, is excellent for both technetium agents. There are also three agents available for measuring myocardial perfusion with PET, two of which are FDA approved. That includes rubidium-82 and N13 ammonia are the two available in the US. O15 water is commonly used in Europe, but not in this country. Obviously, there are differences in half-life. Rubidium has a half-life of 72 seconds, ammonia about 10 minutes. The images of hyperemic blood flow are very good with ammonia, good with rubidium, and the gated images are really excellent on both, perhaps a little better with N13 ammonia. How do we select the stress protocol? Well, in general, in nuclear cardiology, we have two choices. We can do exercise, or we can use pharmacological stress using either vasodilators or beta-1 agonists like dobutamine. The choice will be dependent upon the patient's condition, the clinical question that is being asked, and the safety considerations for each particular clinical scenario. Symptom-limited exercise is always the preferred approach because it is safe, it is most physiological, it is inexpensive, and more importantly, because it provides additional important information regarding exercise capacity, hemodynamic response, all of which are important for prognostication. However, it is important to remember that it is critical for nuclear cardiology to avoid submaximal exercise, and this is because submaximal exercise will lower and affect the sensitivity of the test. And this is the principle we're trying to achieve. Here you have two patients. A patient, one clinical scenario is one patient at rest and during exercise. At rest, you can see that there's no, despite the presence of a flow-limiting stenosis in one of the coronary arteries, there is no heterogeneity on the images. The flow is homogeneous. With exercise, what we're trying to do is we're trying to create flow heterogeneity such that the area that is supplied by the stenotic vessel will show as a perfusion abnormality on the stress images. You can imagine that if you cannot achieve maximal exercise, the difference between the myocardium that is supplied by the normal vessel compared to the stenotic vessel will be minimized, and therefore the contrast between the affected zone and the normal zone will be impacted, and therefore diminish our ability to pick up perfusion abnormalities. And here's what happened when you cannot achieve maximal stress. Your sensitivity for either 1, 2, or 3 vessel disease is going to be lower for submaximal stress testing compared to maximal exercise. And so how do we, with that in mind, then we should avoid at all costs doing submaximal exercise stress testing, and this is where pharmacological stress comes into play. It is preferred for patients who are unable to exercise or who have left bundle branch block or pace rhythms because of artifacts. And as I mentioned initially, there are 2 forms of pharmacological stress: vasodilators, dipridamole, adenosine, and now regadenoson, or beta-1 agonists like dobutamine, similar to echocardiography. Diagnostic accuracy is similar for maximal exercise and for pharmacological stress imaging. In terms of the vasodilator stress options that we have, 2 of them are non-selective. Adenosine and dipridamole affect or interact with all the adenosine receptors, including those in the lung and in the heart. The ones that we're most interested are the ones that the subtype 2A, adenosine 2A receptors, which are, of course, going to be stimulated by adenosine and dipridamole, but will also come with adverse effects from the interaction with and binding to non-specific receptors in the lungs and the heart. Regadenoson, on the other hand, is a specific selective A2A receptor agonist that has the same potency as adenosine or dipridamole, but with fewer side effects compared to these other 2 agents. In terms of imaging protocols, we can do multiple types of protocols. There's the so-called stress-only protocol, where we do only a stress, or we begin with a stress test, inject the radio tracer, wait 15 to 30 minutes, and then perform the imaging. When the images are normal, we don't need to follow up with a rest imaging protocol. So this is a radiation sparing protocol because it can be performed at a very low radiation cost to the patient. Another common protocol, or the most common protocol after stress-only imaging, is the single-day protocol that is either rest-stress or stress-rest. It depends how we start the protocol. If we start with rest, we inject a low dose of technetium, imaging, wait about an hour, do the stress test, inject the second dose of technetium agent, and then do the corresponding imaging study for those images. For patients who are overweight or very large, for single-day protocols, we use occasionally a 2-day protocol where we perform stress and rest imaging at moderate doses on 2 separate days, and then the images are then compared. For PET imaging, the protocol is much faster because the half-life of these tracers is much shorter. Remember, it was about 70 seconds for rubidium, is about 10 minutes for N13 ammonia. So for rubidium, we can complete a rest and stress protocol in about 30 minutes or less. And for N13 ammonia, we can complete a rest and stress study in about an hour and a half because we have to wait for decay of the initial injection of the radio tracer. Exercise can be used only in conjunction with N13 ammonia because it has a 10-minute half-life. Exercise is really not available for rubidium-82 due to the short half-life of the agent. With PET imaging, we collect the same information as we do for SPECT. That is, we collect the summed perfusion images, which you can see here on the left upper side of the slide, which will allow us to delineate the presence and extent of perfusion abnormalities. The images are ECG gated, so we can also obtain volumes and ejection fraction the same way we do for SPECT imaging. One unique aspect of PET is that imaging can allow us to track the rapid changes in radioactivity in the heart as the bolus of radioactivity crosses the heart and ultimately is retained in the myocardium, as you can see in these movie files. And from this information, you can construct the so-called time versus activity curves. And these time activity curves depicts the changes in radioactivity in the blood pool here in green. And then the color pictures are as the blood pool or arterial counts diminish, then the blood pool, the myocardium picks up and the tracers retain. From these time activity curves, then we can generate measures of myocardial blood flow in milliliters per minute per gram of tissue, both under stress and rest conditions, and we can even calculate the coronary flow reserve, which is the ratio between the maximal stress, the maximal flow achievable during stress, and that at rest. These coronary flow reserve measurements, again, are unique to only PET imaging, and what they measure is the integrated hemodynamic effects of the epicardial coronary focal stenosis, the diffuse aspect of atherosclerosis and vessel remodeling, and the changes in the microvasculature as a result of atherosclerosis, including both endothelial and smooth muscle cell dysfunction. All of those changes are measured by the changes in coronary flow reserve, again as the ratio of blood flow during peak hyperemia and flow at rest. The radiation doses in nuclear cardiology are evolving very rapidly, and this slide illustrates the dose, the total body affected dose in millisieverts associated with different type of protocols. You can notice here that the dual isotope SPECT protocol using stressed thallium, using stressed technetium and resting thallium is the highest dose protocol. And now with single or stress-only protocol using modern cameras, we can get as low as 2 to 4 millisieverts, on average about 2 millisieverts here. With PET imaging, the protocols are also very, very low in radiation dose. Notice here in 3D, N13 ammonia is associated with less than a millisievert. So the protocols that we should avoid, if possible, because of excessive radiation dose include, as I mentioned, the dual isotope protocol, including resting thallium, stress, technetium agents, or the straight up thallium protocols, except when we're interested in viability and we don't have access to either PET or MRI. So the comprehensive evaluation of coronary artery disease with nuclear cardiology will involve the detection of flow-limiting stenosis, the quantification of myocardial ischemia, the quantification of myocardial blood flow and flow reserve that is unique to PET, assessment of myocardial viability in those patients who are far along the natural history of CAD and have now LV dysfunction, and then ultimately the quantification of left ventricular volumes and ejection fraction. So let's talk for a minute about applications of nuclear cardiology for the diagnosis of obstructive coronary disease. If we go to the indications and we review quickly the appropriate use criteria, the multimodality appropriate use criteria, we can see that for symptomatic patients, most of the applications will be considered appropriate indications. The one that is rarely appropriate is that when patients present with a low pretest probability for coronary disease and have an interpretable ECG and are able to exercise. In all other categories, either low probability or low pretest probability with an uninterpretable ECG or unable to exercise, imaging is considered an appropriate indication, and nuclear cardiology is one of the most popular, along with stress echocardiography. And then both in the intermediate categories, in the intermediate risk categories and high risk categories, nuclear cardiology is always considered an appropriate indication. In general, for asymptomatic patients, nuclear cardiology or any other form of imaging will be considered either rarely appropriate or at most maybe appropriate, particularly for patients presenting with an intermediate or high risk probability for CAD and have, especially if they have uninterpretable ECGs and are not able to exercise. There are also special scenarios in which nuclear cardiology is always an important adjunct to the clinical evaluation. Those include newly diagnosed heart failure. That's always an appropriate indication, trying to establish the etiology of heart failure, especially the presence of coronary disease. Patients with life-threatening ventricular arrhythmias, evaluation of myocardial ischemia is always an appropriate indication. Patients presented with syncope, especially if patients don't have a lot of risk factors for atherosclerosis, it could be considered maybe an appropriate indication, but is generally being associated with a low yield of positive studies, except, again, when we're evaluating patients with intermediate or high coronary artery disease risk. Follow-up imaging in asymptomatic patients, as we just discussed, is considered a rarely appropriate indication, except, for example, for patients who are intermediate or high risk and present with atypical symptoms that are not considered to be typical for ischemia. That may be considered a maybe appropriate indication. In patients in whom symptoms have developed or worsening symptoms have developed, it's going to be considered always appropriate. For post-revascularization, the key aspect here for an asymptomatic patient is the timing. It is maybe appropriate in intermediate and high-risk patients if they are more than 5 years after their bypass surgery or more than 2 years after their percutaneous coronary intervention. In symptomatic patients with prior revascularization, nuclear cardiology is always going to be an appropriate test. For pre-op evaluation, in general, we consider any form of imaging a rarely appropriate, and is going to be considered appropriate only in patients who have poor functional capacity, intermediate or high coronary disease risk, and undergo major surgery, including vascular surgery or organ or solid organ transplantation. The diagnostic accuracy of SPECT imaging has been published extensively. It is considered to be associated with a sensitivity of around 80%, perhaps for 3-vessel disease it's a little higher. No significant differences are observed for exercise versus pharmacological stress, or for qualitative versus semi-quantitative analysis. Now, that being said, PET imaging is a more accurate technique for diagnosing coronary disease, especially when we are including in the evaluation the quantification of myocardial blood flow and coronary flow reserve. There are 2 or 3 meta-analyses in this respect showing that PET is consistently associated with a higher accuracy compared to SPECT imaging. This is another such meta-analysis including not only SPECT and PET, but also including echo and MRI, and you can see that both PET and MRI are consistently superior to both SPECT and stress echocardiography for both sensitivity and specificity. Now, we mentioned the quantification of coronary blood flow initially, and I'm going to show you a few examples as to how this quantitative information helps us improve diagnosis for coronary disease. Consider this case is a 68-year-old male with hypertension and diabetes presenting with atypical angina. The stress and rest perfusion images here are shown on the slide, and you can clearly see that there is a small but severe perfusion defect involving the lateral wall of the heart, showing complete reversibility at rest. You can see that also here in the quantitative analysis on the polar map, showing that the lateral wall of the circumflex territory is associated with the area of perfusion abnormality. There's relatively normal perfusion, at least visually, in the remainder of the heart. However, when you quantify the flow, you can get a completely different picture. You can see that these are the flows in milliliters per minute per gram at rest and during stress. And you can see that there's hardly any improvement in coronary blood flow when you do the vasodilator stress, especially in the LAD and circumflex territories, and modestly only in the right coronary distribution. The result is that the ratio between the maximal flow and the resting flow, the so-called coronary flow reserve, which should be above 2 in relatively normal individuals, you can see that is severely blunted, and the flow reserve is close to 1 in the LAD, is actually lower than 1, indicating the presence of steel and ischemia in the circumflex, and is severely reduced in the right coronary distribution. The global coronary flow reserve is 1, and in such patient, we would be concerned that in addition to the area of ischemia that we identified visually, there's probably a lot more ischemia that the quantitative analysis is revealing, but is not amenable to visual interpretation. When you look at the angiogram, you can explain why this patient has such a blunted coronary flow reserve. There's high-risk anatomy with a 90% left main stenosis and a 99% ostial circumflex stenosis. So this is an example where the coronary flow reserve helps us improve the sensitivity of perfusion imaging to uncover the extent of coronary artery disease and really detect a high-risk individual. In fact, when you look at the data, the addition of the coronary flow reserve into our semi-quantitative visual algorithm helps us improve the negative predictive value, so that when the coronary flow reserve globally is normal, that means above 2, the likelihood that someone will have severe high-risk coronary angiographic disease is exceedingly low, with a negative predictive value of 97%. How about risk stratification? This is one of the strongest points of nuclear cardiology. There's an extensive data in the literature showing that nuclear cardiology techniques allow us to identify patients at both the low and the high end of the spectrum, of the risk spectrum. The data for a normal myocardial perfusion study is pretty consistent, showing that in the presence of a normal myocardial perfusion scan, the subsequent risk of major cardiovascular events is exceedingly low, perhaps lower than 1% a year. And this applies to all patient studies, to all protocols, to all imaging tests that have been used. So it's a pretty consistent finding. When the study becomes abnormal, it's not a all or none. You can see that there is a gradient, a spectrum of severity that goes from mild abnormalities, small perfusion defects, to extensive abnormalities. And those two patients are associated with very significant risk, such that the risk assessed by a myocardial perfusion scan goes relates linearly to risk, as you can see here in the y-axis. What are the findings that denote the presence of a high-risk myocardial perfusion study? Well, those are summarized on this scan. These images correspond to a patient that have suspected coronary artery disease. And you can see on the stress images, the first finding is that the cavity is larger on the stress images than it is on the rest images. This is so-called transient cavity dilatation, or TID. It's an important finding because it denotes the presence or potential presence of extensive ischemia. The second finding is the presence of multiple perfusion abnormalities, which in this patient involve the left anterior descending coronary artery here, involving the anterior wall, the apex, and the septum, all of them showing reversibility, and also an additional defect here in the lateral wall, also showing reversibility. So large perfusion defects, typically involving more than 10% of the left ventricular myocardium, especially when they involve multiple vascular territories, like in this patient. One other finding that can occasionally be seen is when we examine the raw images, we call them projection images, we can see that sometimes we see increased retention of the radiotracer in the lungs on the stress images. That's always an abnormal finding, because it means that during stress, there is increased filling pressures, increased or transiently increased pulmonary pressures with lower circulation of the and clearance of the tracer through the lung, through the pulmonary vessels, and on the images reflective as an increased uptake of the radiotracer. So again, large perfusion defects, more than 10% of the ventricle, transient cavity dilatation or TID, transient increased RV tracer uptake is sometimes occasionally seen also, and it's a high-risk finding, and transient pulmonary uptake. A couple of additional findings are when we look at the ejection fraction and we see that the EF falls, like in this case, from 62 to 45%. Is a significant drop in ejection fraction with a transient enlargement in the left ventricular volumes. You see the end systolic volume going from 42 at rest to 74 during stress. That's always abnormal. And so to the other four, we're adding now a transient drop in ejection fraction and an increase in end systolic volumes. All of them constituted a constellation of findings that should point to a high-risk scan. As I mentioned before, there is a relationship between the extent and severity of perfusion defects that we see on the images and the subsequent risk of the patients. And this linear relationship has been demonstrated for all types of patients, patients with no CAD, known CAD, post-revascularization, men and women, symptomatic and asymptomatic, etc. So it is a universal finding and it's important to recognize. With PET imaging, we can achieve the same level of risk stratification that you can achieve with SPECT imaging. This is a large multicenter registry showing again the nice separation of risk in patients with normal perfusion scans and those with severely abnormal myocardial perfusion PET scans. The information from nuclear cardiology is also incremental to other information that comes from the exercise stress testing, for example. In this particular study, you can see that the presence of a severely abnormal scan portends a high risk at any level of clinical risk as determined in this case by the Duke treadmill score. Now, the most cost-effective group of patients is always those in the intermediate risk category because of the nice separation between the events between high and low risk. There are some groups for whom a normal scan may not necessarily indicate the presence of a low risk, and that includes, in particular, patients with diabetes and perhaps those with end-stage renal disease. And that relates to the fact that many of these patients have multivessel disease, many of them have microvascular abnormalities that may make heterogeneous differences between regions of the heart more difficult to pick up when we do semi-quantitative analysis. For those patients, the inclusion of coronary flow allow us to improve risk stratification. For example, here are two patients with diabetes, both evaluated for symptoms, atypical angina or dyspnea, both of whom have a normal myocardial perfusion scan. If one would go by the information I mentioned before, you would anticipate that those patients with normal scans will be associated with a low risk. If I now present you with the information from the quantitative perfusion information, the patient and ask you the same question: would you think that these two patients have the same low post-scan risk? And intuitively, you would say, well, perhaps no. The patient on the top has a normal coronary flow reserve, and the patient on the bottom has a severely impaired coronary flow reserve, indicating the presence of diffuse myocardial ischemia. Indeed, when you go to the literature, you see that the presence of an impaired flow reserve in patients without known coronary disease identifies a very significant risk differences between these patients. Patients with preserved flow reserve have a relatively low clinical risk compared to those with severely abnormal flow reserve. Those with severely abnormal flow reserve have a risk that is at least equal, if not higher, to those patients who are not diabetics, who already had either a myocardial infarction or had prior revascularization. So perhaps the flow reserve, because it measures vascular health, it will allow you to determine the true CAD risk equivalent and refine your ability to risk stratify these patients. How do we use this information for guiding management? The key information is in the total amount of ischemia present. And this data has been shown for many years now that there is a relationship between the risk associated with revascularization and medical therapy as a function of the total amount of ischemic myocardium, such that in patients with extensive amounts of ischemia, revascularization seems to be associated with a lower subsequent risk compared to medical therapy. Conversely, in patients with no ischemia, 0, or a mild to moderate ischemia, revascularization does not seem to have a prognostic advantage compared to medical therapy. So this is practical information that is currently being used as part of the decision-making process for deciding regarding revascularization. Perhaps there's an opportunity by the use of coronary flow reserve, like in this pilot study showing that on top of the regional perfusion information, the presence of abnormal coronary flow reserve identify patients who can benefit from complete revascularization. You can see that when the flow reserve here is low and no revascularization, the relative risk of those patients is much higher compared to patients that underwent PCI or, and especially if they underwent complete revascularization with CABG. Even when you have a regional defect, if your coronary flow reserve globally is relatively preserved, there doesn't appear to be a strong advantage of sending that patient to revascularization. So the coronary flow reserve, in addition to giving us an advantage for diagnosing coronary disease, perhaps it will offer some advantage in guiding revascularization strategies. A, when to send the patient to revascularization, and B, what type of revascularization might be more appropriate for a patient with diffusely abnormal coronary flow reserve. Moving on now, very quickly, the role of viability and ischemia testing in patients with ischemic cardiomyopathy. Basically, what we're trying to do with imaging is trying to identify if imaging can give us a benefit signal in patients that otherwise have high risk for undergoing an interventional procedure like coronary bypass surgery. If a patient, for example, presents like patient number 1 with an extensive area of perfusion defect and concordantly reduced glucose uptake, the so-called match pattern that denotes the presence of extensive scar, the enthusiasm for revascularizing such a patient will be low. So the imaging gives us a benefit signal that is going to be low in this particular case. In contrast, if we have a patient that has similarly low ejection fraction, but we see extensive areas of viable myocardium throughout the left ventricle, the enthusiasm for sending this patient to revascularization will be higher because the presence of extensive viability, the presumed value of revascularization in such case will be to improve or remove ischemia, improve ventricular function, and improve survival. Here's an example of one patient that had a previous myocardial infarction. You can see that there is an extensive perfusion defect on the resting perfusion images here involving the anteroseptal wall and the anterior wall, but there's preserved metabolic activity here in the septum and lateral wall, indicating the presence of extensive myocardial hibernation, the presence of perfusion defect with preserved metabolic activity. In this case, the total amount of hibernating myocardium involved 35% of the left ventricle, and this patient here would be a patient that one would consider a good candidate for subsequent revascularization. There have been studies showing that when you randomize patients to conventional versus an imaging-guided approach to selecting candidates for revascularization, at least for PET, there is a benefit, a survival benefit of randomizing patients to performing PET imaging in such patients, because that information, if adhered to, can be useful in identifying the group of patients that will benefit prognostically from revascularization. One element that we need to keep in mind when we're doing evaluations of myocardial viability is the degree of left ventricular remodeling, and we need to make sure that our patient does not have end-stage LV remodeling, because the predictive value of viability testing in such patients is relatively low, and as shown by the STITCH trial, the relative advantage of revascularization in such patients is modest compared to medical therapy. So what is the role of viability and ischemia testing in clinical decision making? If a patient has significant angina, has decent distal target vessels for revascularization, and has a reasonable surgical risk, is not an essential piece of information that one would always need to get. However, in the group of patients that have severe LV dysfunction, that has less than end-stage LV remodeling, that have multiple comorbidities, and where patients have less severe angina, the presence of viability on non-invasive testing seems to be helpful in guiding decision making and balancing risk versus benefit in those patients. Very quickly now, in the last 5 minutes of my talk, we'll review two new applications of nuclear cardiology, one that relates to inflammation and infection, and the other one related to cardiac amyloidosis. For the assessment of myocardial inflammation, we currently use an approach that includes myocardial perfusion imaging and metabolic imaging with FDG. This metabolic imaging with FDG is capable of uncovering cells, inflammatory cells that are using glucose. Like in this particular case, you have a patient with a large perfusion abnormality here involving the anteroseptal wall with a so-called mismatch defect showing increased glucose uptake that turned out to be cardiac sarcoidosis. So the presence of this mismatch in the absence of coronary artery disease implies the presence of myocardial inflammation, and sarcoidosis is one of the prime differential diagnoses. For doing inflammation imaging, the patient has to be prepped appropriately. As I mentioned before, we do perfusion imaging either with PET or SPECT, and then we do FDG imaging. But for FDG imaging, we need to do the opposite of what we do in patients with myocardial viability. Instead of doing a glucose load to study the patient, we will ask the patient to follow a high-fat, low-carb diet prior to imaging to try to force the normal part of the heart away from using glucose and to use fatty acids so that the FDG can be retained in the inflammatory cells infiltrating the myocardium. There are a number of patterns that one can see. Of course, the most useful pattern is, or one of the most useful, is when the study is negative. This is a patient here with normal perfusion and no glucose uptake in the heart, because the heart is using fatty acids and there are no inflammatory cells. That's a normal pattern. On the other hand, you can have patients, as I mentioned before, that have a perfusion defect, like in this individual, who have FDG uptake indicating the presence of active inflammation or active inflammatory cells infiltrating the area of perfusion deficit, and that will be consistent with the presence of focal inflammation. There are other patterns also that is important for you to recognize, including the presence of focal FDG uptake in the absence of a perfusion defect, or when there's some diffuse uptake, but there's also focal increase in FDG uptake. All of them have been signs of focal myocardial inflammation. The presence of inflammation can be not only important from the diagnostic point of view, but also from the risk stratification point of view, allow us to identify patients at low and high risk of adverse cardiovascular events. Last but not least, PET imaging is used for following response to therapy. In this case, we look for reduction in metabolic activity, both outside the heart and in the heart, in response to immunosuppressive therapy. In looking at cardiac sarcoidosis, we typically do MRI first because it is a highly sensitive test, and we only add PET if the study is negative, but we have a high clinical suspicion. In those patients, we do PET. If we start with the MRI and the study is positive, we always follow that with a PET scan because the PET scan will be used to make decisions regarding following up response to medical therapy. Very briefly, FDG is also being used for the evaluation of infection, and what we look for is for focal intense areas of glucose uptake around prosthetic valves or or other metallic prostheses that like ICDs, etc., that will indicate the presence of active infection. One important caveat of this is how to differentiate inflammation versus active infection. In many instances, we require the addition of TAG, white blood cell scanning, to differentiate inflammation from infection. So take-home points. There's a complementary role of MRI and PET in sarcoidosis. Patient preparation for FDG is critical to improve the specificity. The presence of a perfusion FDG mismatch and focal RV uptake are most specific and predictive of risk. And PET FDG is useful for identifying response to therapy. Very briefly, the application of now nuclear cardiology for cardiac amyloidosis, especially for the differentiations of light chain from TTR amyloid. We're using currently technetium pyrophosphate in the United States, which is a bone-seeking agent that for unclear reasons is retained or is binding very avidly to TTR amyloid. You can see in these whole body scans a patient with no evidence of amyloidosis. Patients with light chain don't retain the tracer, but you can see the two patients here with TTR amyloid showing very intense uptake. This has been shown to be consistent for across the different institutions for differentiating light chain from TTR amyloid. There's a consensus document now that shows that presence of grade 2 or 3 uptake in the myocardium in the absence of or a negative monoclonal gammopathy in serum and urine is associated with a specificity of 100% and avoids the need of potential biopsy in such patients. So technetium imaging is useful primarily to distinguish TTR from light chain amyloid and from other forms of non-amyloid LVH. As a reminder, TTR patients are highly positive on technetium pyrophosphate. Patients with light chain are negative or only mildly positive on pyrophosphate. So grading uptake in the reports is essential, and grades 2 and 3 are associated with high specificity as discussed. So now we go to the two questions as part of this presentation. There will be another post-test question which will come separate from this presentation. So which of the following myocardial perfusion imaging protocols is associated with the lowest radiation dose? Here you have 4 options, including single-day rest-stress technetium-99 protocols, B, single-day stress-rest thallium protocol, C, stress-only technetium protocol, and D, single-day rest-stress N13 ammonia PET. And in general, PET protocols are always going to be associated with the lowest risk of radiation, as mentioned during the presentation. The stress-only protocols, which is the other one, is associated with about a 5 millisievert dose compared to the PET protocols, which will be 3 millisieverts or less. Second question is, which of the following ancillary findings is not a marker of multivessel coronary disease on a myocardial perfusion scan? A, transient ischemic dilatation. B, perfusion defect involving greater than 10% of the LV. C, pulmonary uptake on both the rest and stress images. And D, transient increase in RV tracer uptake. And I'm sure you all got it right. Of course, it's option C. Now, option C, you said, well, how come? You said pulmonary uptake was a finding. Yes, but only when it's transient during exercise, not when it's present on both the rest and stress images, as stated in the option C. So option C is not a marker of multi-vessel disease. Well, hopefully this has been a useful summary for you on the applications of nuclear cardiology, and that you do well in your board examination. Thank you very much.